by Nikolay, and he will be talking about the complications and the things in cervical disc arthroplasty. Nikolay, you can share your screen now.
Okay. Can you see my screen?
Yes, we can.
We can see that. Yep.
And can you hear the recording or not?
We can hear you.
Start with some history. Okay, so can you hear the narration or not? Dated back 1950s and 60s, but the first commercialized implants.
No, we cannot hear much.
Okay. Right, so I tried to record it, but anyway, so I will just present it myself. Thank you so much for giving me the opportunity to present. Greetings from Belfast. I'm going to talk to you about outcomes and complications. So I'm going to start a little bit with some couple of slides of history. This is the first devices that have been implanted, 1950s, early 1959. But the first commercial device is available from 1989, which is known as Prestige One. It was commercialized by Medtronic. Later on, we have Brian Disc in 1990s. This is when the companies and the industry actually realized that this is a multi-billion market, and they started developing it. But initially, at the beginning of this century, you can see that I done a search in 2008, and I found only 150 papers treating disc arthroplasty. However, I have repeated the same search just yesterday, and you can see that there is 100 times more publications on the topic now. And you can see that most of them had been done in the last 10-15 years. So why to bother with disc replacement? The compression of neural elements, of course, this is standard for ACDF as well. Sagittal alignment and mechanical stability. Some people are questioning that, but we've seen from Oscar that he's expanding the indications, and this is possible in certain selected cases. ACDF is well known now that is promoting adjacent segment degeneration, and this is something that we are having, and this is why we are looking for alternatives, which could be the adjacent, the disc arthroplasty. So in my hands, indications. Mobile motion segment, adjacent level of disease, restoration of the motion segment, decompression of the cord and nerves. Usually I use that in single or multi-level disease. In my hands, 1 or 2 level max, 3 levels on a push, but I haven't been above 3 levels. So we have seen that Oscar is doing 4 levels in certain cases. Yes, I don't see why not, but I still haven't started doing this many levels. Usually, if I have many levels, I will consider hybrid solutions. So in my practice, contraindication will be hypermobile segment. If I see normally angulation of more than 2 degrees and translation of over 3 millimeters, I wouldn't do it. Marked spondylosis and facet joint arthrosis, there is no motion there, I wouldn't do it. More than 3 levels, I wouldn't do it. And if the patient is osteoporotic, severe OPLL, kyphotic deformity, trauma, or infection, I wouldn't do it. Standard Smith-Robinson approach, with I will surpass the midline with my skin cut, because that is preventing push of the tissues will not push you to contralateral site, and like that you will be easier to keep the midline. And midline is very important when you are introducing your disc arthroplasty device. These are some points that you have to consider when you're doing arthroplasty. If you over-destruct, not only the patient will have pain because of the joint over-destruction, but you will put the device in an unfavorable position and it will not work well, and it will give you complications. If you don't keep the midline, that might happen again. If you are too much forward or too much backward, or if your disc is not the right size, you may have problems as well. So if you compare TDR with ACDF, of course, the TDR is having in favor motion restoration, reduce the adjacent segment disease, and reduce risk of pseudoarthrosis. And with the ACDF, we have better restoration of sagittal alignment. Multi-segmental pathology is better addressed, and that is something that, sorry, I have some problems with my presentation. Better multi-segmental pathology restoration, and in that respect, wider restoration. So if we if we see the literature now, we have a good body of publications that suggest that the arthroplasty is reducing the level of adjacent segment degeneration, and unlike the disc, the ACDF that is promoting the adjacent segment degeneration. So based on this, there is now good research that suggests that you will have significant reduction of your reoperation rate, and also that will incur a lot of savings long term. The way that is happening is because the ACDF is actually reducing significantly the range of motion, obviously of the index level, and that is increasing significantly the pressure of the adjacent segments. It is well known now that the 50% of the intradiscal pressure, the intradiscal pressure goes up with 50% of the upper adjacent segment and 125 of the lower adjacent segment. In that respect, we have to also say that if you have multi-levels that are treated with ACDF, the intradiscal pressure of the first healthy disc above or below is significantly times more increased. So there is also now a good body of information to suggest that if you're doing ACDR, you are not exposing your patient to extra risks. So the risks with the ACDR are similar as with the ACDF. Heterotopic ossification is one of the negative outcomes of the ACDR. Many people are criticizing this, and there is, in some publications, up to 63%. I think this is too much. Maybe this is technique dependent. Other negative outcomes of the TDR are reported as longer surgical times and increased blood loss, not in my hands, spinal malalignment, and osteolysis. It is possible. I haven't had this so far. And vertebral body fracture. Haven't had that, but this is something that's been described, especially with certain disc arthroplasty devices, which have the keel in the middle. And if you do multiple levels, you have to drill a keel of the upper and lower end plate of the same vertebra, and that may expose that vertebra to risk of fracture. Implant misplacement is obviously a complication that can happen if your cage size is not good, or if you if you put cage that, arthroplasty device that is too small, or it is not properly anchored. Metal hypersensitivity reaction and loss of lordosis are also possible risks. So before I continue, I wanted to show you this biomechanical study. This is a recreation of the way your normal disc is moving. This is the disc this is a normal disc in a normal individual that is moving not around axis of rotation, but it's moving also together with coupled translation. So like that, you have a centroid of rotation, but not axis of rotation, which unfortunately is not what we see with most of the available disc arthroplasty devices at the minute. Ball socket design is typical for that, and you will see ball socket design moving around a center of rotation, but not centroid the way your normal body is moving and normal disc is moving. So in line with this, the pitfalls of the cervical arthroplasty surgery, you should avoid not over distracting. You should keep the midline. You should increase, because if you don't keep the midline, that will increase the wear and failure. It will increase the wear and the failure will increase if your footprint is smaller or bigger, or if your implant is not properly centered. Stress strain curves of the implants are also something that will demonstrate that despite the modern design, we are still away from the normal strain stress curves of the normal disc. Maybe we have now something that is closer to the normal disc motion with the soft core devices, which are now available in the market. I have seen that Oscar is using that. Unfortunately, I was possible to use this device, but not anymore because they lost CE marking due to some new in Europe. So finally, I would like to show you a case that I have done. This is one of the first cases. 46-year-old patient that presented to me with a history of ACDF C6-7 done 5 years ago, and he was okay for 5 years. But then he started having again radicular symptoms, and the MRI scan showed adjacent segment C5-6 degeneration, which explained his symptoms well. So what I have decided to do is I have decided to do a disc arthroplasty at level C5-6. And you can see these are the postoperative x-rays. The patient was okay for 2 months, but then again presented to me with significant radiculopathy and numbness of both arms, consistent with C5-6. I've tried to treat conservatively for a couple of more months, but the symptoms were not subsiding. The patient was actually forced to keep his hand flexed, to keep his head flexed. Otherwise, we'll experience severe symptoms. While I was appreciating that my cage, my arthroplasty device is too anteriorly located, I tried to alleviate the symptoms conservatively, but that was not possible, so I decided to revise. You can see this is interesting picture to show you that when I placed the patient in supine position, this is the level check just before I start operating, just before I start removing that disc. You can see the how much it is gapping in front. So there is clearly instability at that level, and it was the right decision for me to go and revise the level. So what I have done is I have removed the arthroplasty device and I've replaced with cage and plates. You can see that this cage is a bit too big, 9 gauge. Maybe a few of those I have used in my whole practice. Not many 9s I have used so far, but the space was good for 9, and that's what I have put, and the patient is well at the minute. So of course that we could learn from that case, and criticism would be that I have placed the cage, the arthroplasty device too anteriorly. and maybe this caused all of the problems later. Thank you so much.
Thanks, Nikolay, for a great talk. Sérgio, would you like to add?
Nothing special. It's a good advice to when we see this kind of outcomes and complications. It's a warning for what we have in real life. Sometimes is not what we plan, and we need to adapt and look for the better to the patients. So it's a nice presentation by Nikolay.
Yeah.
So what I have found, sorry, what I have found in when I do these cases is unfortunately, because I am not possible to use now soft core, just not available in the market here. I have to use these ball socket devices, which are very, very demanding in terms of you have to place them right in the center. It has to be the right size, and it has to be very properly placed. Otherwise, it is asking for complications. While if you use these soft core arthroplasty devices, I feel that they are a bit more forgiving. I would like to ask Oscar to comment on that as well.
Sure. I mean, socket ball devices, the center of rotation is completely different from the normal patient. You know, center of rotation is located really higher up in relation to the disc. The only biomechanical advantage of socket and ball is lateral flexions. The range of motion is quite good, which is very demanding. You need to do a very good uncus decompression, because they will bend laterally quite a lot. But I agree. I mean, if you use this kind of 6 degrees of freedom that they are compressible, they will adjust more to the facet joints on the back, and they are protective of the facet joints. And they also show a little bit of anterior slide movement of the superior end plate, like in normal physiology. So clearly, it's an advantage.
Yeah, what people don't realize is that when you are doing a cervical disc arthroplasty, that surgery is more demanding and more, you have to be more perfect in your surgery, and in your end plates have to be absolutely parallel. You have to drill out the uncle joints pretty nicely. Your disc size should be just perfectly measured. It should cover the whole disc as much as possible. Otherwise, you won't get a good range of motion.
Yeah, fully agree. You know, the widest end plate coverage as you can. And you know, I mean, always remove the PLL. Always do it, because you need to see the dura. The PLL is like a scaffold for ossification.
Yeah.
For heterotopic ossification. So I'll give this tip. Everybody is doing arthroplasty should remove the PLL and should do uncus removal beyond the compression, because there will be problems.
And that's what I always tell my juniors, that doing ACDF is surgery while performing arthroplasty is an art.
Yeah, it's more forgiving.
You have to be a good artist to do that. Yeah. So now the last talk is by Joachim. I don't see Joachim here.
Yeah, actually, he's in India and traveling from the meeting place to hotel. So then we need another 5 minutes for him to start, and we can continue discussion.
Yeah. Okay. So
yeah,
Oscar, I'll start
my
with you. You have
question
so
is,
much of experience. Which disc do you, what disc do you prefer and why? Which disc do you like the best?
So, sorry, did you ask Oscar? Yes.
I asked Oscar first. I'll ask you the same thing later.
Yeah. Sorry, it was breaking, so I didn't get who you're asking.
So
Okay.
no, I mean, I can't give you a name. I'm not affiliated with any company. I don't have any contract, but I certainly avoid implants with keels. It can damage the end plate. It favors ossification. You can have fractures, as Nikolay said. So any device that you can that has this compressible 6 degrees of freedom, it's really what you should use, in my opinion. There is no place for this old type of devices, first and second generation.
And Nikolay, what about you?
I totally agree. So as I showed you that this was the most problematic case that I had with after arthroplasty, and I don't know if I'm wrong or right, but I blame it on, of course, it's my technique, but ultimately, as you said, if you're doing ball socket device, and this was a ball socket device, you have to be really, really perfectly centered. Otherwise, if you are not, you're asking for problems. So, and in that respect, my preference is for these softcore devices. I was using a device. I'm not affiliated as well. I know I'm going to say a name. Unfortunately, that is not available anymore. At least I believe in Europe. There was a striker device that was called Rhine, and it was perfect device. Unfortunately, they've lost CE marking in Europe because of some new legislation that came lately, and they are not possible to sell it. So I now don't have what to replace it with. Maybe I will ask Oscar, because I've noticed that he's using something that I like.
Right. Sandeep, I have a question for you, if I can make questions.
Yeah, sure, of course.
I'm not moderator, but it's something I'm interested. We are looking now at this, all our patients. We started this 15 years ago in a systematic way, and we follow the patients. It's the topic of anterior osteolysis. Do you see it in your cases or not?
Not really.
Neither do I. I mean, I think the timeline of osteolysis has not yet been published. We don't know yet really well. On all our cases, we have day one X-rays. The next day after surgery, before the patient goes home, is discharged. We have a good baseline to compare. And honestly, we are not seeing what some papers 1 year ago, 2 years ago described massive osteolysis in this kind of patients. I don't know what about you, Nikolay.
Neither do I. Now, see, previously our follow-up of the patients was not that great. So I'm talking about the cases that I did it in 2004 to 2010 maybe. But after that, since other social media things came, WhatsApp, and patients are more communicative, they message their problems very fast. So now we are following up the patients pretty regularly, and now there are many patients who are more than 10 years follow-up. I don't really see any extra ossification in any of those. Most of them are pretty happy. I try to get an X-ray. There is no fixed schedule. I do it immediately after surgery and after 3 months. But after that, patients, they are doing well, they don't come. But those patients who come, sometimes we do the X-rays, and I see most of the disc still working. I see good movement even then. So I'm pretty happy with it. And as far as the disc is concerned, we have to use whatever is available with us. For first many years, it was only the Bryan disc. Then Prestige came in. For last many years, as I said, I stopped using the discs with keel. And so for last many years, I've been using Spineart's Bagheera, and I'm pretty happy with it. Though again, I'm not also affiliated with any company, but yeah.
Right. And another important topic, and Nikolay mentioned that, you mentioned that I had patients done with 4 levels. Yeah, but there are not many. It's very hard to find 4-level disease that needs an operation. And once you have 4-level disease, you probably have different levels of degeneration. So you can do very nicely hybrid constructs. It's what I recommend to do. So less mobile, almost no motion, why to insert a disc prosthesis. So I fully agree. Hybrid systems are really good for multi-level disease. It's probably the best of both worlds, but it comes to patients that you can do 3-4 level, and there is no problems with primary stability of the implants. It's reliable.
What about posterior surgery in 4-level disease, particularly if there is good lordosis?
You mean it depends on multiple factors? Yes,
Yeah.
but we do it, of course. Yeah, I mean, young patients, with narrow congenital stenosis, minimal disc disease. We can offer no neck pain. We can offer laminoplasty.
Laminoplasty, yeah.
You know,
Yeah.
all the rest I tend to do fusion, laminectomy and fusion.
Dear friends, I have two concerns. One is that the cost effectiveness, the cost of the arthroplasty is somewhat higher, although you mentioned that it's not different from ACDF. But in our countries, we can make the ACDF with the bone graft only, and then we must pay for arthroplasty. Although we have also domestic companies who are producing arthroplasty devices for Turkey also. The second issue is that the heterotopic ossification is still there. Are you thinking that even it ends with the fusion, it works? It is good. Do you think that heterotopic ossification is not a issue against arthroplasty?
Right. You know, that study that I showed with 10 years follow-up, range of motion was preserved. It's a really nice study, although HO was 43%. And that's what the literature basically shows. You can find HO, but prostheses are, most of them, mobile in different degrees, of course. I mean, there are several tips and tricks to avoid heterotopic ossification. And I think most of the causes are technically related. Of course, you have patients that tend to show more this than others, but it's also a technical issue. And there are tips and tricks that can help on that. As I said earlier, the bigger the end plate coverage, this is for me number one factor to avoid HO. Then what I do also anteriorly, always put some bone wax between the disc plate and the end plate of the vertebral body. This fills this little gap with bone wax below and above, and this avoids in some way seeing these huge anterior ossifications. The other one is obviously a prosthesis that is perfectly working. You know, like Sandeep said, really centered with a good biomechanical footprint. If it's not biomechanically sound, of course, ossification will appear. And another trick is always to remove the PLL. As I said, PLL is definitely a scaffold for ossification. So it's a lot of elements here that if you follow them, you can reduce your HO rate quite a lot. On our paper, the HO for multiple levels with 4 years and something follow-up was like 18%, 20%, following these techniques.
The same I want to ask also Nikolay about the cost effectiveness and the issue on ossification, heterotopic ossification. What do you think, Nikolay?
So yeah, cost effectiveness, I think, Mehmet, I think that it is, yeah, it's still slightly more expensive in UK, but it is not much more expensive comparing to what it was. The cost went significantly down. So now the two prices, at least in my practice, are not very far away. I don't see so much heterotopic ossifications in my patients. I remember when you invited me to one of the spine masters in Istanbul, you asked me to deliver, this was in 2015 maybe, and you asked me to deliver a talk on disc arthroplasty, and I delivered why I don't do disc arthroplasty. But then I started, but I don't have as long follow-ups as Oscar. But I don't see much heterotopic ossification in my practice. Maybe I don't follow them long enough, or maybe I don't have enough cases. I don't know, but Oscar said 18%. So in the publications, it goes from 12 to 63% in some publications. I don't see so much, and I'm pretty convinced, like Oscar said, it's technique related.
Yeah, Mehmet, coming back to your question about cost effectiveness, I mean, it's clearly that the rates of reoperation, which adds to most of the costs, are lower with arthroplasty, either adjacent segment or even index level reoperations. And this is basically what accounts for best cost effectiveness studies. We don't have many studies, but all of them tend to show that arthroplasty is more cost effective. And as I said, the price of the devices change a lot in different countries. Obviously, if I'm doing a fusion, I'm not using PEEK cages anymore. I can have PEEK cages here in my country for 200 euros. But I don't use them because the rate of pseudoarthrosis is quite high. So if you go for an option of cages with embedded screws, this is more or less the same price of an arthroplasty device in my country. So this, I don't have a bias on this at this level. Hi, Joaquim.
Good.